So I want to welcome everybody to tonight's Compass MS Care program. This is an event that MS Views and News began prior to COVID, and we've been doing this in rural America around the United States. And I know you guys don't feel that you're rural, but some of you might have come in from outside of Madison, and so we just felt that this is a good place to do it rather than at a silo along 90 or 94, okay? All right, so today's program is sponsored by, and I want you all to thank them as well. We have EMD Serono, Genentech, Novartis, Sandoz, TG Therapeutics, and Viatris. If it were not for them, we could not do these programs, so I want you all to please give them a round of applause and say thank you. Say thank you, thank you. All right, great. So for those that are in the local area, I'm sure you know Dr. Luzio very well, and for those that are online, he's an MS neurologist. Dr. Luzio is an MS neurologist at the University of Wisconsin Health, and he's a designer of assistive devices. Now, I met Dr. Luzio at CMSC a few months ago, and I went over to his table and I saw some of his inventions, which really out of this world, all right? And I can't wait for him to have one day a chance to talk with you about that. But right now, he's here to speak about 12 questions that you should be speaking with your MS neurologist about. So let's welcome Dr. Luzio. Depends which mic I want to talk into.
Hello, everyone. Can you hear me? I'm supposed to hold the microphone like this, so remind me if I let it drift. Thank you, MS Views and News, for having me here, and for all of you for attending that are here in person, and all of you that are listening online. I have to warn you that I've been in clinic all day, but that doesn't matter. I can talk about MS for days straight, but I have terrible stage fright. So I have let my heart rate go down because I think right now my heart can generate electricity. So 12 questions you should be asking your MS neurologist. These are, I was thinking about this presentation long before I was asked to do it. And I've been wanting to do it actually for our residents and at other venues, because I find that in the clinic, there are these most common questions that patients ask me, and I talk about them all the time. And that's what I'm going to present to you today. Common questions that are often asked, and some that you should ask if you haven't asked them or thought of them. This is supposed to be a very qualitative type of presentation. I'm not going to talk about p-values or statistics, just, bottom line important stuff. And also remind you that a lot of things that we recommend are not based on absolutely proven science. Some of it is somewhat common sense, and some of it is sort of views that have been accepted because they seem to make sense. So I am a neurologist at the University of Wisconsin, and I've been there now since for 22 years now, since 2002. But I was there previously. I was trained at UW. I did my residency there. And I graduated from residency in 1997. Then I worked for a couple of years at UW. Then I went to California and realized I couldn't afford to live there and raise a family. And I really liked Wisconsin. So I came back here. And I'm really glad to be here in Wisconsin. I love Wisconsin. I consider myself a Wisconsinite. And I became an official Wisconsinite recently, not because all my kids were born here, but because I actually own a stock certificate from the Green Bay Packers. Now I'm an official Wisconsinite. So what I do is I take care of patients every day. I participate in MS clinical trials, but my academic work is actually in neurosurgery, in the devices that are used to regulate intracranial pressure. So the slide on the left-hand side is a platform system that I designed to simulate intracranial pressure and spinal fluid flow through the brain. And my neurosurgical colleagues and I, we test prototype valves that drain excessive fluid from the brains of children. My passion is not only taking care of people, but also mechanical engineering. I was trained at UC Berkeley in that. And then when I'm not working with the neurosurgeons in the late afternoons and evenings, I work with engineering students, and I teach a class called Design for Rehabilitation, and we design devices that are specifically for patients that are assistive devices to help improve the quality of their life. And the device on the, did I say right before I meant? On the device on the left there is a mechatronic trombone. And that is a touch-activated trombone. It slides at 2 meters per second, and that's for a person that's mostly quadriplegic. My neurosurgeon colleagues and I, we jump-started or initiated a company called Madison Scientific, and that's really my only disclosure here. But that company has nothing to do with MS. My fun fact for the evening is that I planted a vineyard, and I've been experimenting with making wine, and they're my first bottles of wine, sort of a rosé. I just planted 25 little vines from Minnesota, and hopefully in a couple of years we'll get some red wines. Okay, so first question is, what is MS? You've been diagnosed with MS. You've gone to the doctor and they've given you a disease. So your first responsibility to yourself is to learn as much about MS as you possibly can. Buy books, read online, go to the MS Society's webpage, and try to learn as much as you can from other patients and from the nurses and from your neurologist. In this slide, I'm going to touch upon just a few things, really. First is, what is MS? Where does it come from? Why does it even start? I mean, it really is somewhat of a mystery, and it still is. You've been told that it's an autoimmune disease, but is it really just an autoimmune disease? It has components of being an autoimmune disease, meaning that your immune system attacks the central nervous system. It attacks the spinal cord and the brain. That's where the battle is being fought in multiple sclerosis. MS against your body. It's in young people, the most common, it's the disease, the neurological disease most common to cause, or most likely to cause disability in young people, central nervous system, meaning brain and spinal cord. So it's been called an autoimmune disease, which means the immune system comes in across the blood-brain barrier and starts munching on myelin and the cells that produce myelin. These cells that produce myelin, they protect your nerve transmissions. That's what myelin is. Think of it as an insulation on on wires. Your wires don't short out that connect to your TV because they have plastic surrounding them and insulation. That's what myelin is. It protects the fidelity of nerve transmission. And without it, you're short out. But why does the immune system do that? What caused it to do that? One of the leading theories is that an environmental agent has triggered MS in your body. And one of the leading contenders for being responsible for this is the Epstein-Barr virus, the virus that causes mononucleosis. And the theory is that it's affected the myelin-producing cells or the myelin or the nervous system in such a way that now it's recognized as being foreign. And now the immune system wants to come in and attack it. But in theory, though, if that was the case, then immunomodulating and immunosuppressive drugs should completely squash it and stop the autoimmune attacks and stop the disease from progressing. Because as you know, MS has relapsing component and a progressive component. Some people have mostly relapses, and some people have mostly progression of disability, of neurological dysfunction, and some people have a combination of the two. Take away the relapses. We do that with our MS therapies, our immunosuppressive therapies. They stop the relapses because they're pretty good at keeping the immune system away. But what are you left with? Some of you are left with a quiet period of remission, a long remission, and nothing happens again. The probability is very low, and that's great. And that does happen to a lot of patients. Others, however, continue to have progression. And they ask, well, why is my disability still progressing if I've got these great drugs that are immunosuppressing me? Because the other component of MS is a neurodegenerative component. And this is all theoretically. But whatever's happened to cause MS is not only inviting the immune system to come in and attack the myelin, but it's also causing a chronic dysfunction in these cells that produce myelin, that regardless of taking away the immune system, that dysfunction is being propagated. And we don't know exactly what that is. And if it is the Epstein-Barr virus that's responsible for most of this, we don't understand exactly how it's done it. That's a hot topic in MS. How do we stop progression? And how did the original problem begin? Should I take MS drugs and which one? This is a giant topic. It's a giant topic. And it's become more complex in recent years. When I started, there were only a few medications. I got interested in MS by being invited to do a clinical trial on Rebif. That was in the year 2000. And I thought, wow, this is a really interesting disease. This is a great population of people. I think I'll just continue and become an MS specialist. And that's how I got into it. I actually didn't do a fellowship in MS. I was doing neurorehabilitation and doing other things at the time. So why do you take MS drugs? The most important reason is to stop the relapses, because relapses put you in the hospital and they add to neurologic disability. Because every time you have a relapse, there's an injury there. You take away the relapses and your body only has to deal with either some of that progressive dysfunction or no progressive dysfunction at all. But stop the relapses. If you stop the relapses, years later, you'll have less disability than if you did not take these medications. Also, there's evidence that your lifespan will be lengthened. It's true that in most MS patients, your lifespan is the same as the person in the general population. Take the medications early in the course of the disease. They work better. They work better. It's early in the course of the disease where the relapses are most common, more frequent. And that's another interesting thing, is why is it later in life the relapses tend to disappear? I have my own theory about that. It's not anything that's scientifically proven. And every time I say something that's not proven, I will tell you, because I have my own theories. I'm allowed my own theories. I wonder if the reason why relapses are less frequent later in life is because simply the immune system doesn't care anymore. The disease is still there, but it doesn't care it's there, and it's not attacking the myelin and the myelin-producing cells anymore. That's my own theory. Sort of like when you get desensitized to bee stings and insect stings. Take the medications, start them early, because you will not regret it years later. And I'm not here as a messenger for the pharmaceutical companies. I just want to add in my disclosure that I'm not being paid by them tonight. MS therapies keep people out of the hospital. And in general, people do better on them, especially for relapsing MS. Problem is primary progressive MS. Primary progressive MS, that's minus the relapses. And you just see this downhill slide. That's a hot topic, and that's difficult to control. We have one medication right now that's FDA approved for that. That's a B-cell depleting drug called ocrelizumab. But even when people take that downhill progression still occurs at some rate. By the way, that medication is also FDA approved for relapsing MS, and it works very well. I can't mention every drug here, but I will mention a few when it becomes necessary or important. Now, which medication? I'm going to talk about that in the next slide. But first, why not take medications? What if a patient chooses not to take a medication? What am I going to say to them? Well, if they're young and the disease is severe and there's lots of lesions on the MRI scan, I'm going to say, no, I really think you should take a medication. I'm going to encourage them. If a patient's had MS for a few years and looks like it's mild, and in 15% of patients, it will be extremely mild, and they don't want to take them, and the MRI looks fairly clean, I'll say, yeah, okay, I'm not going to push you to take meds. Exercise, eat healthfully, that's okay. I'm going to go back to the slide, the first slide for a moment. And I wanted to point out in the far pictures there, the cartoon on the very right, it shows a yellow brain. when doctors are referring to the lesions that are periventricular, look at the little orange spots that are surrounding that white ventricle in the middle. Those are called Dawson fingers. And I want to bring up some of the vocabulary. What is a Dawson finger? That's a lesion that follows or surrounds a vein. And that's a circle or a volume, a sphere or an ovoid of inflammation. The lymphocytes are coming out of the vein and they are attacking the myelin producing cells. That's a classic lesion for MS. The other classic lesions are juxtacortical lesions. And you can see there I drew some red lesions there that are right up against the ribbon, the cortical ribbon. Now, when lesions are not up against the cortical ribbon, we have to be suspicious that we're not dealing with multiple sclerosis. And if they're not following a vein, we have to be suspicious that we're not dealing with multiple sclerosis. Our job is to make sure that you're not misdiagnosed. Now, when doctors mention ring-enhancing lesions, what the heck is that? Well, acute MS lesions are associated with an open blood-brain barrier. And when they give you the contrast, gadolinium contrast, that flows across the blood-brain barrier, and we see the contrast accumulating in the brain, and it forms a ring, only because the MRI has taken a picture across this ovoid. So it's like grab a hot dog and cut through a hot dog, and you look at it like this, and you see a ring of a hot dog. That's what a ring-enhancing lesion is. And that's in the MRI picture to the left of the cartoon there. And up above is another cartoon I drew that shows an axon with the oligodendrogliocytes producing myelin that surrounds it. And there's a nearby blood vessel, and the lymphocytes are crossing the blood vessel, going to the myelin and destroying it. That neuron connects to a lower motor neuron to the right there that then connects to a muscle. Those lower motor neurons are in your spinal cord. They're not affected by MS, but they are in diseases like Lou Gehrig's disease, So when you have a dysfunction of that upper motor neuron, the lower motor neurons aren't being activated to control your muscles. So there are a lot of MS drugs, and it's not as easy a task as you might think for a doctor to choose your medication. Some doctors are going to bring you into this discussion and say, I'm thinking of a few medications for you. How do you feel about these? One might be an infusion every 6 months. Another could be pills every day. Another could be a self-injection. And each of these medications has a particular sort of range of side effects and potential problems. And you might see a chart in our clinic that was developed by our clinical pharmacist over to the left. Now, this chart is a chart of efficacy or effectiveness of the drug versus the relative safety of these drugs. Now, there's something about this slide that you have to understand. This is a teaching tool, but this is not something that could be published as an absolute relative sort of performance between these drugs, because to do that, you have to test every one of these drugs against every one of the other drugs. You see what I mean? Otherwise, scientifically, it doesn't hold water. But as doctors, we can say, well, we know that some of our older drugs aren't as good as some of our newer drugs. They don't work as well. We know that from the clinical trials. And so we can sort of use these associations that we have in our mind that do make sense to sort of explain to patients, well, your MS is really mild. You're doing okay. You're not someone that's headed downward very fast with this disease. We can use one of our milder medications that has less probability of you developing infections, okay? Because the things that we think about when we start a person on a medication is their age. How old are you, okay? Can you do a self-injection? What are your abilities? Are you going to be very compliant with your medications? Are you considering family planning? Do you have other diseases that keep you from taking certain of our medications? Those are all the things that are playing in our head, and we talk to you about them. So we may dismiss a group of medications because you've been exposed to a certain virus. For example, natalizumab, we would not use that medicine, also called Tysabri, if you've been exposed to the JC virus, which, by the way, this is another question that comes up. The JC virus is in half of us. It's just one of these sort of piggyback or hitchhiker viruses that lives in most of us. It doesn't do anything unless you become immunosuppressed. And then the virus says, I can take advantage of this situation. I'm going to go to a person's brain. So if we want to use the Tysabri, we would prefer you not be JC virus serum antibody positive. Now, the question that comes up in a lot of other patients is, well, some of the other medications some of those patients have had the JC virus infection, which when it manifests itself is called PML, progressive multifocal leukoencephalopathy. Should I be on these medications if I'm JC virus positive? The answer is yes, it's fine. The only medication where that is really a big deal is natalizumab. But so over here on a chart, that chart there, you see rings of blue and rings of green and rings of yellow. And that's simply sort of the blue rings are medications that you take by pill, and the green ones are infusions, and the yellow ones are self-injectables. And then over to the right is a list of all the potential side effects and possible adverse effects that you could be afflicted with, many of which happen actually fairly rarely and at low probabilities on many of our drugs. They sound terrible. When you read about them and hear about them on TV, they sound terrible. But quite frankly, most of our medications are safely used by most all of our patients. And don't be afraid of using them, because we can safely use them. And I have for 20 years. Rarely has the medications ever caused such a serious problem that my patients' lives were in serious danger. We have a responsibility to monitor you for that safety. For example, the medications that we call the fumarates. Every 6 months, you get a CBC to make sure that you're not too immunosuppressed. We monitor absolute lymphocyte counts. So you could talk hours about this, and I could go through every medication, but that's not the purpose of this. The purpose of these slides here is to emphasize that it's really important for you to seriously consider being on a med and being informed about the medications you're on. Ask to see charts like this. See what you're taking. Be informed about all the different medications. Ask questions about them. Now, common question. I'm on my MS drug, but my leg is still weak. I'm still numb. MS drugs do not heal lesions. That's not their purpose. Their purpose is to prevent new attacks, new lesions. That's their purpose. Now, some of our medications, however, once people have been on them, they notice that maybe it has been noticed that, well, healing is accelerated a little bit in these folks. Why is that? I have a theory. When you take one of these medications, it removes some of the immune pressure in those plaques, in those lesions, and allows the body to heal them, because an MS plaque, an area where there has been inflammation, a lesion, is healable. Your body can fix it. It can put the myelin back on as long as the axons are preserved. Another reason to be on MS drugs. If you suppress the immune response, then you also reduce the probability or the possibility that axons, the very tube of the neuron, is not being destroyed. Because the more inflammation there is, the more that the axon itself is going to be destroyed. And if the axon's destroyed, it's not easy to put everything back together. You can't put the myelin back on if the axon's gone. But if there was less intense inflammation, then the myelin can go back on the nerve. Your body will do it. What about acute MS relapses? What do you do about those? That's when you're having an attack. And that's when there's active denervation, active inflammation. That can be treated with high-dose IV steroids or high-dose oral steroids, methylprednisolone. But you don't have to do it all the time. Should I take the steroids, doctor? Possibly, maybe. How severe is the attack? If it's a subtle amount of numbness, it may be better not to take the steroids, because steroids in themselves also have side effects. You can get avascular necrosis of a bone, which means the blood supply is cut off from the bone and you lose your femoral head, or you lose part of your jawbone. Using steroids frequently is not safe, and they should be used judiciously. Now, if I miss the boat because I've not taken a steroid when I'm having an attack, in general, we believe that no, that the steroids help shorten the attack, but they don't maximize or they don't improve recovery. Well, recovery will occur to the degree at this level, regardless of whether you've been on the steroids or not. Steroids are to help reduce or limit, to limit the time frame of significant attacks that are impairing quality of life. A pseudo-exacerbation, another common term you hear. What is that, doctor? What is a pseudo-exacerbation? A pseudo-exacerbation is an exacerbation that is not associated with active inflammation or active lesions. It's your MS symptoms rising up from old lesions because something is affecting your body and drawing energy from your body. For example, a cold virus, or being out in the heat too much, or excessive exercise, I'm saying. We'll get back to exercise in a minute. Pseudo-exacerbations will heal completely. They'll go back to normal, just fix the problem. Get the urinary tract infection healed, get out of the hot weather. Will exercise hurt me? Absolutely not. I'm asked this question every week in and week out. Exercise only helps you. It reduces fatigue. It promotes healing. It lifts up your endurance. And there's a lot of evidence for that. So work with the physical therapist, work with a trainer, work with your family, find an exercise program that you can do. Not everybody can run, not everybody can jog, not everybody can be on a stationary bicycle, but most everybody can do something that moves their limbs. And also, and I've been actually saying something which I thought was true, and I realized after reviewing some papers in the last few days about exercise, I used to believe that that aerobic exercise was actually the best for MS. And I realize now that it's actually a combination of strength type of exercise, exercising against resistance, like lifting weights, and also aerobic exercise, meaning moving your body. So combination of both of those is good for MS. You will not have an exacerbation from exercising, but you have to exercise to a degree that your body tolerates. If you can run a mile, that's great. But suppose you can only be on a stationary bicycle for 15 minutes before you get overheated and you get so fatigued you can't do it anymore. That's okay. Find your limit, do it regularly, because regular exercise is important. And then keep doing it, and then try to raise that limit a little bit. Water therapy. Everybody's talking about water therapy, and there's a reason. There are studies out there that show that water therapy improves fatigue, depression, and balance. So I show a tank there. Not everybody has tanks, but lots of people have access to swimming pools. And it's amazing how many places around the country are offering water therapy or a place for people to get in a swimming pool, people who are disabled. Why is it good? It's good because water lowers your temperature. Elevated temperature causes weakness. That's called Uthoff's phenomena. You might hear that. What's Uthoff's phenomena? Oh, that's me getting weak when I'm heated up. So temperature's down, buoyancy. Buoyancy is the you floating in the water. You can't fall. So if you're one of those people that is at risk of falling, being in the water is the best place to be. You can't fall. And if you have some floaties, you're not going to drown either. Drag. Water provides drag. That's important. That's the resistance. That's your resistance training. Okay. By the way, that's the transit of Venus there from 2012. All the astronomy pictures I took, by the way, that's Venus in front of the sun. And up above is a physical therapist. There are all types of cool devices that physical therapists and occupational therapists have at their fingertips now to help you improve and learn how to exercise, learn how to regain your balance. Devices with harnesses, devices that provide a three-dimensional environment. It used to be the physical therapist would put an object on a treadmill, and to practice balance and maneuvering, you'd have to avoid that object coming at you at the treadmill, a physical object. Now it can be a virtual object. And there are treadmills that are two-dimensional treadmills. You can walk forwards, to the right, and to the left. They've got these complicated systems of tracks that mechanical engineers like me love to look at. What's the best diet? When I put this down here, I knew I was in trouble because this everybody wants to know, should I be on the Schwank diet? Should I be on the Walls diet, the Mediterranean diet? Okay. The consensus is eat for your heart, a well-balanced diet. Now, there are some studies that show that your quality of life might improve a bit if you reduce foods that are difficult to digest, like red meats. They'll take a little more energy to digest. Maybe you should shift more to fish, for example, as in the Mediterranean diet. But the key is moderation. Keep your weight down. Junk foods, eliminate them. Processed foods, eliminate them. Eliminate foods that you're allergic to, that don't agree with your digestive system. I lean towards the Mediterranean diet because I'm Italian, and that's a dish there that I prepared. Now, that pasta would be my carbohydrate for the day. The meatballs in the middle, okay, should be fish. A lot of Sicilian dishes are fish. That's lean meat. And I'm not going to eat 20 meatballs. I might just eat 2. And then up above is a salad with olive oil in it. If you're going to eat pizza, have a giant salad with it so you eat less pizza and more salad. And then a glass of wine, a little glass of wine. Alcohol is okay as long as it's in moderation. No, it's not a full glass of wine. It's just a finger's width. That's okay. Down below, by the way, is my garden, just for me to emphasize that when you go to the grocery store, think about getting foods that you cook. Think about fresh foods. And there are studies out there that show that our microbiome likes green vegetables. It doesn't like processed foods. Now, coffee is okay, dark chocolate's all right, smoking, bad. Get rid of smoking. Smoking is, here you are taking a $100,000 MS drug that puts you a little bit at risk of getting pneumonia, urinary tract infections, and what are you doing? You're smoking. Come on. This is terrible. You're battling a disease that's, that could be, gnawing at you like termites to wood, and you're smoking. Smoking destroys your blood vessels. All right, what are the barriers to actually eating good foods? Unfortunately, economics, access, motor abilities, going to the grocery store. That's the reality of it all. Try to do our best. So eat for your heart. Eat foods that are good for your cardiovascular system, and you're eating good for MS. That basically is the take-home message. Should I have a family? Absolutely. Is that what you wanted to do? Before you're diagnosed with MS, did you want to have a family? Did you want to have children? Then do it. Don't change your life plans for MS, because I'll tell you why. A significant portion of people with MS will have very normal lives, will have very minimal disability. I'm not going to sugarcoat it. A chunk of patients are going to have bad disability, and the disease is going to be horrible, and it's going to be frustrating. But even those people should live the life as they want to live it. Don't let MS define who you are. Don't let it take control of you. You take control of it. You go into family planning if that's what you want to do, and we will help you with family planning. I have a patient I was speaking to today. Her name is Lori Schneider. It's okay. She's public. Okay. There's no conflict of interest there. She climbed the highest peak on every continent after she was diagnosed with MS. Some of you have probably heard her speak. And I have a lot of patients that haven't climbed mountains, but a lot of them still do the things they want to do, even though they might have a weakness in a leg or an arm. So don't let the disease control you. Have a family. Now, the next question is, wow, am I going to pass this disease on to my kids? Unfortunately, there's a little bit of a tendency for MS to run in families, but it's not something that we can predict, like you can predict that in Huntington's disease, a certain fraction of your progeny or your children are going to have Huntington's disease. It's not like that with MS. I have a lot of patients with MS that no one else in their family has MS. But the reality of it is that if I have MS, then my siblings and my children or my parents have a couple % increased probability of also having or getting the disease. And if I have an identical twin, that person has a 30% probability. That tells you that there's something about our genetics that makes us a little more susceptible to disease. But is that a reason not to have children? No. Is that a reason for you to test your children for MS when they're completely symptom-free? No. And they shouldn't be encouraged to do so. Now, family planning in MS has become more complicated because of the medications. And that's the next slide. And you can't see these slides. You don't have to. This is in our neurology academies files and so forth. What this is a collection of information, a collection of recommendations that are made by our thought leaders and our leaders in MS to help people determine, okay, what to do with their medications when they become pregnant, what to do with them when they're starting family planning. Do you stop the medication? Do I become pregnant on my medication and then stop it? Do I stop the medication after I become pregnant? Now, for a long time, it was believed that Copaxone was the only gluteamine acetate, which has been here for years, more than 25 years now, was the safest medication to be on if a person was pregnant. Now, we're learning that there are a little more options than that, but it's a moving target and it's changing every day. And it's also different between what's recommended by the FDA here in the United States and also what's recommended by the Europeans and their agencies that make recommendations on medications. I don't just knee-jerk respond to patients and say, it's okay to take this med if you're nursing. Because yesterday compared to today may be different. I go to the list and I say, what are they recommending today? Can I nurse and take my medication? So it's very important that you work with your neurologist to understand some of this. When you decide, I want to have a family, what should I do? Should I stop my medication? I stop my contraceptives? What do I do? And then also work with the perinatal specialists. Now, with this topic are some other questions that come up with pregnancy. And that is, am I going to make my MS worse by being pregnant? No. There is no good evidence that states that if a person becomes pregnant with MS, that in the long term, their MS is going to be worse. That's not the case. It may fluctuate. MS may become a little quiet while a person's pregnant. There may be a little bit of an increased probability of having a relapse once the pregnancy is completed or downstream from nursing. But it all balances out. In general, people are no worse after being pregnant. Does that make sense, everyone? Okay. What is the MS hug? Comes up a lot. It's an uncomfortable feeling around the chest, the abdomen, the thorax of people. It just comes out of the blue. And it feels like either your chest is on fire, it's hypersensitive, or it's being squeezed. And that's the MS hug. Now, the importance of the MS hug is making sure you don't have something else going on, because a lot of other things can mimic the MS hug. And that's why I brought it up here. You have to make sure you don't have GERD. That's the acid reflux. That you don't have angina, which is heart pain. That you don't have an ulcer, gallbladder disease, a pulmonary embolus, aortic dissection. So you have to not assume that the MS hug your symptoms are the MS hug. That's very important. Theory is that it comes from lesions in the spinal cord. One theory. You can treat it with muscle relaxants and neuropathic types of pain medications that many of you have heard of, like gabapentin and Neurontin and pregabalin and Lyrica. Those are the generic and non-generic names of common medications that are used to treat this discomfort. It's not dangerous. It's just irritating. Oh, by the way, that picture there, that's a lunar eclipse, and you can't see it, but the planet Uranus is nearby. And no, it's not pronounced Uranus, by the way. It's Uranus or Uranus. Okay, is this MS? First of all, I'll point to the slide over to the right. Those are reflex hammers that I machine. I learned to be a machinist many, many years ago. And I went to a school that taught us, if you can use your hands, you'll never starve. If you go to college, you find out you don't like college, you don't want to be an engineer or a doctor, well, you can go back and go into the trades. I went to a trade school and a college prep type of school. I learned to be a machinist. One of my first passions, one thing I've loved for years is standing behind a mill or a lathe and turning metal and machining metal. So I make those for our residents. When they graduate, everyone gets one. They're made out of brass. So is this MS? This is, again, not assuming that what you're feeling is due to the disease. And I want to make sure, Stuart, how much time do I have? Am I good? Okay, good. All right. Is this MS? Some examples. New weakness in your body. It's MS. You go to the ER. It's MS. Actually, I shouldn't say that. Our ER doctors are really good. Our ER doctors are smart. They're not going to just assume everything is MS. But let's say you go online. It's MS. You go on, your heart tells you it's MS because I got this problem. Everything's got to be this problem. I don't want to go to the ER. I don't want to deal with new problems. You got to be careful. New weakness spreading from your legs upward. Is that a spinal cord lesion or are you getting Guillain-Barré, which is a completely different problem? It's a demyelination of your peripheral nerves triggered by sometimes an infection like the Campylobacter jejuni infection that causes a GI food poisoning type disease. A symmetric rising numbness that when it reaches your waist, the classic form begins to involve your hands. Case of the hand numbness. I'm dropping objects all the time. At night, I wake up and my hand is burning with numbness and I have to shake it out. Then it goes away. MS numbness doesn't go away if you shake out your hand. It's always there. What you have is carpal tunnel syndrome. The most classic sign of carpal tunnel is waking up in the middle of the night and your hands are numb and you're shaking it out and they feel better. They're numb at night because when you lay flat, fluid from your lower part of your body goes to your upper body and swells your wrist and compresses the nerve that's being compressed in your wrist, your median nerve, the nerve that brings your thumb in. Case of the foot drop with hip pain, herniated disc. We see them all the time in the MS clinic. Got pain that goes down my leg. I got a new foot drop. It's MS now. It's like my other dang foot. No, it's not. It's a herniated disc. And there's ways that we can determine it by physical exam. Chest hug. I've already said this. I got this MS hug again. It's a searing pain, but now I can't breathe. And now, I'm going weak. It feels like I'm having a stroke. I'm having an aortic dissection. So be careful about these things. Terrible searing pain in the chest is not the MS hug. Case of the mouth sores. This is rarer type of stuff. I have mouth sores, and in my brain they saw lesions, new lesions, look like MS lesions. I have another autoimmune problem. It's called Behçet's disease. So your doctors are also responsible to make sure you don't have other autoimmune diseases because they are common in patients diagnosed with MS. Or the person doesn't have MS and they've simply been misdiagnosed. Always report new symptoms. MS misdiagnosis. Your doctors need to always make sure that you have the correct diagnosis because it's not unusual for really at any one time in the United States for maybe a few % of people diagnosed with MS don't have MS. They have vascular disease. They have a headache syndrome, or they have psychiatric disease or somatization disorder or something like that. MS is usually associated with MRI findings, typical physical exam findings for the disease in most all the patients, spinal fluid findings that are compatible and consistent with the disease, a clinical course that's consistent with the disease. And if it's not there, your doctor's got to be suspicious for it. What are some of the red flags that a person doesn't have MS? No optic neuritis. Most people who have MS get optic neuritis at one time in their life. Severe vision loss is not typical of MS, but typical of some of our other MS lookalike diseases, like neuromyelitis optica, for example. Negative spinal fluid findings. Now, some people with MS that can be diagnosed or is diagnosed using our special criteria called the McDonald criteria may not get optic neuritis, but if someone whose diagnosis looks a little suspicious and they've had this diagnosis for years and you look in the charts and no optic neuritis, I better investigate this a little further because maybe this person shouldn't be on, a medication that's depleting their B cells. No MRI changes. No findings consistent with MS. That's a red flag. Eventually, people with MS should have classic MRI findings and a contradictory exam. And that's for your neurologist to find out and figure out. Neurologists are sort of sneaky. They'll do tests on people to see, I'm going to see if this person has something else that looks like MS, but I'm not going to tell them I'm really looking for this. And that's their job. They're supposed to do that. MRI, one of the most common things that comes up in my clinic. I need an MRI every year. No, you don't. No, you don't. Not necessarily. When you're first diagnosed with MS, frequent MRIs are the norm. We have to make sure that a person placed on their MS drugs is doing well on their MS drugs. So you might have an MRI 6 months after you start a new drug. You'll get an MRI or should get an MRI, and a lot of patients in which the diagnosis is not clear, frequent MRIs, I should say. More MRIs to determine, person looks like they're getting MS, we better check. Let's do sequential MRIs. Okay, the person's been diagnosed with MS, start them on medication. A few months later or 6 months later, get another MRI to establish a baseline to make sure that their drug is doing its job. You need 2 MRIs to have a baseline once somebody's been diagnosed, because you really don't know when the new lesions have occurred. Suppose you have an MRI 6 months later, and you've started a medication, you see a few more lesions. Well, did those lesions there, did they occur a week ago, a month ago, at the time they were being diagnosed, just a short time after the drug was started? You don't really know. So 2 MRIs establish a baseline. Okay, the person moves forward. They're stable. When do you get the next MRI? Maybe a year later is okay, as long as they're stable. Or 6 months. 6 months to a year is okay, as long as they're stable. And we probably should do that for a couple years in the early course of the disease. All right, person's been stable for 5 years. No relapses. They're doing really well. Physical exam is stable. Do you need an MRI every year? No. You can go to every other year, or maybe every 3 years. What if I've chosen to stay on that drug that's associated with the potential to getting PML or the JC virus? I'm positive for JC virus, but all the other drugs don't work, and for some reason or another, I got to stay on this medication. Well, your doctor may choose to get an MRI every 4 months to make sure that you're not getting that infection because you're positive for being exposed to that virus. So that may be a case when we're using more frequent MRIs. Later in life, I'm 60 years old, I haven't had a relapse for 15 years. Should my doctor get MRIs? Not necessarily, no. But my doctor now wants to stop my MS drug. Should he get an MRI? I do. That's another consideration. Get an MRI then. Look at what's going on. This patient wants to stop their drug. Economically, they can't afford it anymore, but they're stable and it's reasonable to stop their drug. Get an MRI. Okay, do we always have to do an MRI with gadolinium contrast? No. Standard of care now, and we were just reviewing this in the veteran system. By the way, I work at the VA, UW Hospital, Fort Atkinson, Meriter Hospital, 20 South Park Clinics, UW Hospital Clinics. And the VA recently had some web conferences and getting clear, what is the established, what is the consensus on getting gadolinium contrast? And this is also with non-veterans too. You don't always need gadolinium contrast. For follow-up MRIs where a person's stable, no new symptoms, physical exam is stable, you don't need the contrast all the time. What it does is it costs more money. A person has to get an IV in the arm. They're dealing with the symptoms of the gadolinium. They don't need it. Should I always get a spinal cord MRI? No. No. People often demanding that spinal cord MRI. You don't need it. If you have new symptoms that are referable to the spinal cord, then yes. You get the MRI of the spinal cord. If I'm a person that had very aggressive disease in my spinal cord, then yes, we would do more follow-up of the MRIs of the spinal cord, but not routinely for the average person. So why the brain and not the spinal cord in the stable patient? Well, MS can hide easily in the brain when we're doing follow-up MRIs. You may not have new symptoms when there are new MS lesions, but in the spinal cord, that's such a small piece of eloquent tissue that there's no backup there. A new lesion in the spinal cord is going to show its head. It's going to rear up with new symptoms most of the time. What is my prognosis? I touched on this a little bit, and I'm going to be a little qualitative, very qualitative here. Prognosis is a function of a lot of things. Females do a little better than males. Diagnosed earlier in life, a little better. Early 20s versus, let's say, 40s. That changes a bit for kids, though, okay? I'm not a pediatric neurologist, but MS can be pretty harsh on kids diagnosed that early. But we're talking about adults, and I want to stick to that. I want to stick to the people I take care of. So, female, diagnosed earlier, mild symptoms such as sensory symptoms, starting with optic neuritis, infrequent relapses, relapses where the symptoms recover very quickly, relapses where the motor system is not involved. that indicates a good prognosis. Bad prognosis is motor attacks, incomplete healing, frequent attacks, attacks soon after the first attack that involve motor symptoms. Yeah, I think you sort of get the idea. Being diagnosed a little later in life, being male, unfortunately, there's sort of a gender bias there. But in general, a significant portion of the patients are going to do extremely well. 15%. Like I said, the outside person would never know that person had MS. Now, the person who has MS, like, I got fatigue, I got a lot of things going on. And that's where you got to be careful about in the workplace. When you're trying to explain to people, it doesn't look like I have MS, but it really bothers me a lot. Okay. But that person will still be walking. I would say that in my clinic, 15% do extremely well, 15% are not it's hard on them. And we do our best to help them through it. And then everybody's sort of in between. A lot of those people in between can work many years, raise their families fairly unencumbered. This comes back to exercise and how to take care of yourself. Here's a group of people in the middle that if they don't take care of themselves, they're going to do poorly. If they do take care of themselves, they're going to do much better. Does it make sense? So it's sad to see the group that will do better with MS not doing better because they're not taking care of themselves. So let's look at the natural history of MS just in untreated patients. Patients don't get medications. 50% need a cane or wheelchair by 15 years. Now, this is without medications, okay? 10% never develop serious disability. I think it's closer to 15% myself. 67% work full-time at normal wage. 30% of severe attacks that result in significant disability will not recover completely. That's a severe attack where there's major disability in one attack. 50% have some degree of cognitive impairment. Let's focus on that for a minute. It's not dementia. It's not like getting Alzheimer's. Most of people, it's a little more difficult, multitasking. Sometimes I have word finding difficulty. And that's pretty common in a lot of patients. That can be treated with exercise, sleep, reducing fatigue, reducing stress, eating healthily, and recognizing what you can and can't do. Now, in our older patients, and the gentleman before said he doesn't remember what the past slide was, right? Well, you get to 60 years old, you get to your 50s, unless something's really important to the average person, they might not remember what they ate the day before. They don't care. They might not know what their spouse said to them an hour ago. That's normal. So some people, when they say, well, I've been having an MS cognitive thing, that might just be normal. Just talk to the general population. All right. So let's go on to the next slide. How do I treat fatigue? Exercise. That's the best way to treat fatigue. However you possibly can. And I know I'm going to say it again because when I see people that are in walkers and wheelchairs, it's how can they possibly exercise? Do what you can. If you can move your arms, move your arms. Work with a physical therapist to find out what you can exercise. Actually, the meds that we prescribe for fatigue are fairly controversial. There are studies that suggest they don't work at all, like amantadine, Provigil, Nuvigil, methylphenidate, no better than placebo. And the insurance companies love that. Said, I'm stopping all of your patients on Provigil. They don't get it. It's only for sleep shift disorder. So, the fact of the matter is, a lot of my patients actually benefit from those meds, and I don't quite understand why, but they do. And I'm not going to take them off of them. Patient says, I stopped this med, I can't go to work. I believe him. So a study says one thing, but then another study in 2024 says those wakefulness promoting agents actually do work. It's difficult. Stay out of the heat. That'll worsen your fatigue. Exercise, diet. Diet means eat healthily, keep your weight down. Some of my patients, some folks, are 50, 40, 60 pounds overweight. Grab a sack of cement. Now, I do it all the time because I do my own construction. A sack of cement is 60 to 80 pounds. Throw that over your shoulder. I feel like my back is going to break. That's a huge amount of energy that's expended. Gotta keep your weight down. If there's, forget about all those little nuances and those diets and everything. Mediterranean diet, Schwank diet, Wall's diet. Eat moderately, keep your weight down. Heck, you can have a McDonald's hamburger every day with a salad as long as you don't go over the recommended calories for your day, and your weight won't go up as long as you have a little exercise mixed in there. And by the way, that's why it's important to understand the calories you're eating and the calories you're expending and the calories that you need to sustain your current weight. So if I weigh 200 pounds, I go onto the internet, I look at a calorie counter, or excuse me, a calorie calculator. This is my height, this is my gender, this is my weight. How many calories do I have to eat every day to sustain this 200 pounds? Well, 2,600, but I want to lose weight. So you go on other websites and you start adding up the calories of the foods you eat. Get a feel for this. Well, I'm going to make sure that I don't eat, more than 2,200 calories a day, and your weight will start going down. Doesn't work very well unless you mix it up with some exercise. Fatigue, back to fatigue. Sleep. Sleep's important. Get your 8 hours of sleep and also learn to nap. Efficiency. Don't take 20 steps to go upstairs to get the laundry. Take 2 trips. Or excuse me, I didn't mean 20 steps. I meant 20 trips. Figure out how to make your day efficient. Okay? Occupational therapists are good with that. Again, it's probably 10 o'clock now. These guys are going to yank me off the stage with a hook. But every one of these things we're talking about, it's another 15 or 20 minutes just to talk about, just to touch on these things better. Heat. Let's go back to heat for a second. Heat and humidity. Keep yourself cool. I have patients that want to go out in the garden. What do? Get the garden hose and saturate your clothes with water, because evaporating water takes away excessive heat. Get a big industrial fan and stick it in the garden and blow it across. Heck, they do it in vineyards to protect the grapes from things. You can do it in your own garden. I have patients that do it. They do that. They get a fan and they keep themselves cool, because moving air evaporates water. Evaporating water takes away heat, and that's what you need. That's why on a calm, humid day, you're going to feel like miserable. You're going to be miserable. Okay. All right. Should I tell my employer I have MS? No, not unless you really have to. Now, if you're a NASA astronaut, you got to tell them you got MS, right? I'm not sure about airline pilots, but I'm sure they probably have to too. And I know there's certain professions that the employer has to be informed when there are certain conditions that could put the person in danger and other people in danger. But if you don't have to tell your employer, don't tell anyone. It's your business. Unfortunately, there's still the environments where people are looked at differently when they have a chronic condition. And everything may be blamed on your MS. Oh, we can't keep that person hired. What if they make a mistake, or what if they do this? I have a lot of patients that actually with severe disability, and their employers knew it. They kept working and working, and they did great in their jobs. And I have to applaud their employers. I know of one person whose employer used to send people out in the parking lot, go get that guy and get him and stick him in front of his machine, because it's hard to find people to do what he does. And we applaud him for wanting to keep working. Work is good for MS. Disability may be necessary, but it's not preferred, because when you're employed, you get benefits. When you're employed, you get more money. But most importantly, employment puts you out in society. And also, it's an exercise. Think of it as exercise. I'm exercising my brain. What's the cognitive exercise I'm doing today? I'm exercising my brain by doing my job, by talking to people. I'm moving around the workplace. That's why employment is important. Don't let the work environment poison you or hurt you or harm you. Know your rights. Go to Wikipedia and look up the America with Disabilities Act and so forth. I can't read it from here. I should go to the eye doctor because I need the right glasses. But you go to the doctor, what do? They give you a disease. That's why doctors avoid doctors, because we know that, right? And also at the same time, when you're in the work environment, and no one here does that, that's employed, don't bring your disease to work. In other words, people don't want to hear about your medical problems. Medical problems should stay at home unless they are really affecting your job. So what I'm saying is that if your MS is affecting your job, then you've got to be honest. You got to come forward with that information. You have to say, I can't control this. I can't control this device anymore. My hand is not steady enough. Maybe I better speak to HR. Maybe I better get on short-term disability and have my doctor fix me if he can. What I meant is there's a lot of emotion that's associated with having chronic diseases. And if that emotion is overflowing, don't bring it to work. Take care of it outside the workplace, because that's not good for the workplace either. I think you all understand what I'm talking about, right? Now, I put question 11 and another question 11 down below so that we'd have a total of 12 questions, because the next question really is not a medical question, question number 12. So I had to make 11 there. Alternative question, can I vaccinate? Comes up often. Can I vaccinate with what? Vaccinations do not cause MS relapses. Vaccinate according to what is recommended by the vaccination schedule for the person going to their family doctor who says, protect me against the nasty things out there that I need to be protected against. That's recommended by primary care, and do it. Now, what are the exceptions? Make sure that your doctor knows that they should not be giving you live vaccines, because we don't recommend them in people with MS, particularly people with MS that have immunosuppressive drugs. So that's sort of a bottom line thing. Extreme caution with live vaccines. Now, there may be cases where a person needs one, and I think those are less and less and less, but find out. So, but the primary message here is vaccines are not going to hurt you. They're not going to make your MS worse. Now, that doesn't mean, though, on that very, very rare occasion, a very rare probability, small probability, the vaccine may result in something like Guillain-Barré. But it's not just in MS, people with MS, it's in other people too. That's a risk we take when we don't want to get the flu. By the way, if you do get conditions like the flu, it can land you in the hospital. You get a pseudo-exacerbation. You want to protect yourself against these common animals that are, that will take you down and allow your MS symptoms to flourish. Not new lesions, but the old lesions rising up again, giving your symptoms back when you have the flu or a cold or COVID. And I know COVID's controversial. Yeah, let's not even go there. But maybe we should. Maybe we should a little bit, because I have a responsibility to you to tell you what, in general, what the medical establishment is recommending. They're recommending that people be vaccinated for the COVID virus. Okay, that's what's recommended. That's what's recommended at UW. Okay. Alternative question. We did that. Next one. Anyone know what it is? Pardon me? Number 12. I was going to have an icebreaker slide too, the first one, but I didn't think that Stuart here, I think he said, come on, don't put stuff like that. I know he didn't tell me that, but I figured he might. My icebreaker slide was the questions you shouldn't ask your neurologist. And I was going to do a survey, but keep politics out of the discussion. Okay, last question. Anyone? Last question. I'm a Wisconsinite. Actually, I was born in Kentucky. Spent much of my childhood, or after 9 years old, in San Francisco. Then from there, I lived in Kansas for a while, then Wisconsin. All my children were born here. I paid mortgages here. Spent most of my career working here. Most of my friends are here now. Should I be a Packers fan? Are we going to beat San Francisco? Are we going to beat them? I am tired of us. That's my hometown, by the way. I am tired of the Packers losing to San Francisco. All right. So that's a picture of an eclipse I took August 21st, 2017, Casper, Wyoming. And then I went to the recent eclipse in Clinton, Arkansas. Now, I've been to a lot of MS meetings around the world and a lot of different places, and I've been in some fancy hotels when pharma was allowed to pay for me. I know. Okay. By the way, I'm not being reimbursed by pharma tonight. But never have I been in a hotel that cost more than the Super 8 in Clinton, Arkansas, February 8th, 2024. You know how much that hotel cost? In Casper, Wyoming, they were up to 800. In Clinton, they decided to keep them a cool 400. And that was actually reserving it years earlier. I reserved my hotel in Casper 3 years earlier, and no one knew at that time what an eclipse was or that would bring all this people traveling. But then in 2017, these hotels learned, wow, these crazy nuts come and see these eclipses. So they're plotting all the eclipses. Okay, there's one in 2024. So even years earlier, Super 8, $400. The next one in the United States, 2000, total eclipse, totally solar eclipse, 2044, and then 2045. There's one in Egypt that's pretty interesting in 2025. If anybody can go there, I don't know if I can or not. I'd like to, but I'm just an MS doctor. We don't make the big bucks, and we don't. That's okay, because I love taking care of my patients, and I like teaching my engineering students at the university. And I'm done.
Thank you. Thank you very much. So
I mostly held it up like this.
I got to let you know in Niagara Falls for the eclipse, they were throwing people out of hotel rooms that had booked long before when they learned that they could make 10 grand for one night.
That's Niagara Falls.
That's right. That's right. All right. Anybody in the room have questions for the doctor? Great. I'll be there in a moment.
Yes, ma'am.
This is my wonderful doctor, but I do have a question in regard to the correlation between MS and cancer. Like, what are the newest studies saying?
None. There isn't really a good correlation, but you have to be careful because some of our medications, increase a little bit of the probability of getting like skin cancer. The S1P modulators, there's a little bit of increased probability of getting like squamous cell carcinoma and basal cell carcinoma. That doesn't mean that we shouldn't use these medications. They're actually really good. They're convenient, they're excellent, and they have very minimal side effects. But like all medications, even aspirin, comes a potential, problem. So it's important when you're on those meds to make sure you're looking at your body often, and even occasionally maybe seeing a dermatologist.
Thank you.
Thank you, Dr. Lucius. I have two things that I want. Well, number one, I missed if the live or dead vaccine. Which one should we avoid? The live?
Live vaccines. We're not recommending people take.
I have one other thing to say. Dr. Lucius, this is the second time I got to hear you listen. And how many people here are from the Madison area? Because, okay, then you need to hear about this. We have a group that meets the third Saturday. We used to meet at a restaurant before COVID and that, but you should get in touch with that. One time only 4 people were there. Last time we had a potluck. Sometimes we have speakers. Dr. Lucius was one before the COVID when we used to meet more often. And it's really a good group. It's like another social group. So I'm just going to give you an email address that you can look up these things. And it's Jim Turk. So JMTURK at, I'll repeat it, livelive.com. Jim, JMTURK at live.com. And the other thing they do is what they call a shakedown. And that's, we have people internationally. Sometimes we hardly have anybody there, but it's at noon and it's like upper body exercises. And some of the exercises are almost exactly like what I had when I went to gentle exercises and chair exercises. But if you go to that website, you'll be able to find out what it is. And it's also social time too for us, but it's really good. It's really good. So I wanted to share.
Thank you. Thank you. All right. There was a question online.
I want to go back to the question about cancer.
Sure.
I want to go back to that because that actually is I just sort of said quickly there isn't a direct association. I think that answer or that question deserves an answer that's probably far more complicated than what I gave. I think that the actual process of MS, unless there's literature I haven't read, does not directly cause cancer, increase the probability of cancer. But there are a lot of things that go on in a person's life who has MS. With respect to diet and exercise and medications they take and just other changes that occur in their life that maybe might predispose them to developing cancers. So maybe there might not be a direct reason or direct cause from MS, but there might be secondary things that lead to that increased probability. That's actually a complicated topic, but I'm unaware of any direct causes. I hope that makes sense to you.
Thank you.
So I'm a little bit confused, and here's where the confusion is you were saying to avoid live vaccines, but when I went in for my vaccines that were recommended for me because of MS, COVID was recommended. Isn't COVID alive?
No.
It's not a live
No.
one?
No.
Oh.
No, it's not.
Tell her what it is.
It's a type of RNA. It's a type of nucleic acid. And it is not alive in the sense that it could cause an infection in you.
If lesions that you get in your initial MRI when diagnosed, and if those lesions have not changed or any additional ones, let's say in 8 years, is that an indication of what you might predict progression?
Well, it is true in many patients that after years of MS, you don't see many MRI changes in terms of new lesions. Unfortunately, you might see black holes forming from old lesions that are sort of dissolving away. The brain is removing the material from that inflammation from years ago, so you get black holes forming. And because of that, you may see the ventricles enlarging, and also because of a lot of microscopic activity from MS that's not so obvious on an MRI scan, you might see some atrophy of the brain, just general shrinkage of the brain. But when you reach a point where there are not new lesions forming, that means the autoimmune part of the disease, the inflammation part of the disease is subsiding. And yes, a person's either going into the secondary progressive stage or in which there may be in which there is person to person very variable declines. There may be no decline at all. And in some people, it may be fairly precipitous. After years of MS, the next little bite of MS that it takes from a person may seem to make a bigger impact because a person is losing the reserve. But remember at the beginning when I said that MS is quite variable from person to person, and the progressive component of it, which is, in my opinion, always in the background, may be fairly minimal in some people and fairly significant in others. If it's significant in others at the get-go, then they're going to end up with disability early on. If it's not significant, then maybe that later progression is really those old lesions that are associated with neurologic dysfunction. And those areas that were affected, those lesions now are sort of, they're like bruised apples and bruised fruit. Their function is disappearing sooner than it should with old age. And then you get a progression associated with that, not directly from the disease process, but from the secondary problem of having had those lesions. But an indicator, though, that a person may be entering the secondary progressive stage is progression along with no MS activity, new MS activity on MRI. Does that make sense? Usually later in life, years or decades after, let's say, a 20-year-old or 30-year-old has been diagnosed with the condition.
What are hyperintensities that appear in the brain scans on MRIs?
Well,
and you answered the question about black holes.
Yeah. Hyperintensity is sort of a bad term. It really is. Does it mean, when you look at an MRI, there's different sequences. In other words, the software is changed in a way that, for example, water may look white or bright, or fat may look white or bright, or the myelin and the white matter looks gray, and then the cortex of the brain looks a little less gray. And so in certain images, a lesion will appear bright. It'll appear like white, like somebody got a paintbrush and just, touched the MRI. That's a hyperintensity. The reason why I don't like that term is I like to be more specific. Okay, there's an MS lesion there, okay, and it's in a non-contrast scan, it's showing itself, there it is. On a contrast scan, a person referring to a hyperintensity may be actually referring to a very active lesion, a lesion in which there's active inflammation. So to answer your question, though, in general, what they're referring to as a hyperintensity is an MS plaque, an area where there's been inflammation. The question is are they really answering the question that's important to the neurologist? If you've had contrast, is that enhancing with contrast, or is it a non-enhancing hyperintensity? Does that make sense?
Thank you. Next one.
Hey, Dr. Luzio, just had a quick question on the diet. I know you touched on like Mediterranean diet, and
yes,
I've heard that over the years that can be a benefit. But I was hearing about I think it's called a DASH diet. Stuff with like a very low sodium diet. Are you seeing any like data that
there is, and I'm gonna precede the answer with some other background information. Understand that the studies in diet are few, that in recent publications, the consensus is if we really want to make an impact on people, on opinion on this and recommendations, we better do more studies. But it's really hard to muster up the money that it's required when there's not going to be a gain. Nobody has a patent that's going to pay off on this. And that's why you won't find too many studies. And if you do, they're very smaller populations of people. So it's really hard to say this is better than that and that's better than that. But to answer your question, there was a study that was done that suggested that high salt diets are not good for MS. And that's where that's coming from. And I'm afraid to say something that's not true, so I'm going to be generalized. I believe that study was from the East Coast, and maybe it was from Johns Hopkins. I don't remember, but it was a low salt diet or a salt studying diet study. So that's where that came from.
Okay.
Yes.
Hey, my first question, I'm going to have many, are a high instance of like psychiatric disorders, do they increase with MS lesions?
Yes. And so depression is very common with MS. So there's an increased probability of depression in particular. And also with cortical lesions, because you think of MS as affecting the deep white matter, okay, of the brain. And if you have enough of the white matter affected, you're going to have people that will have impulse control problems and judgment problems, things like that. But in my experience, even a few small lesions on the cortex of the brain where we do our thinking can result in psychosis. And along with that, possibly seizures and hallucinations and acute memory problems.
All right, let me get to a few of them that were online, please. First one, somebody wrote, I think you said something about steroids and femoral head issues.
Yeah.
So the question is it only steroids that causes that, or can an MS drug actually cause that condition as well?
I am not aware. What we're talking about is avascular necrosis of the femoral head. So you have one artery that goes to the femoral head and it supplies blood to your bone. Your bones need a blood supply. Without blood, your bones will die. So there's one single artery that goes to the head of the femur. That's the femur is the bone that goes from your knee to your hip, and the head of the femur plugs into your hip socket. And this unpredictable adverse effect from steroids, which happens enough that it actually frightens us, not common, but enough, is that all of a sudden the blood vessel just closes up and it starts blood. It's like having a stroke. And I am only aware that that can happen with steroids. I am not aware that that can happen with MS drugs, or I haven't read of such a case.
Thank you. Next one. During an exacerbation, would you recommend having an MRI to show disease worsening?
The strict answer is that most people with an exacerbation should have an MRI scan. Now, to show new lesions, because there has to be decisions that need to be made based on that. The reality is that doesn't happen all the time. And that's a problem, and I don't like it. And I'll tell you why this is a problem. Access to our clinics and our hospitals is difficult. We are very congested. Now, we get to know patients, and I will, if I know a patient and I believe what they're telling me over the telephone, I may simply prescribe medications and not get that MRI, or we may get it a little later. But frankly, what should be done is somebody's reporting what sounds like a true blue exacerbation. They should have an MRI scan, and then you should document new lesions and move forward. If somebody has an exacerbation, we're obliged at some point in the near future to figure out, should they be on a different MS drug, or should they be on an MS drug? Some of these patients may not even be on them. So, but unfortunately though, in the real world, all the things we want to do and all the things we should be doing can't be done easily.
Okay. Next one starts with a paragraph about you. This doc is great. He's very thorough. He said
nice.
something that I learned since my beginning with MS. Steroids do not affect MS in the long run, and I've only heard this addressed when I'm the one that brings it up. I wish he practiced in Miami, but if he did, Maria, he'd have to become a Dolphins fan. All right, next. Another person writes, I have PPMS. Nobody else in my family had it. Is there a test to determine if my daughter will get MS?
Earlier, I said it's not a good idea to test asymptomatic family members for MS. It's just not recommended. So that's sort of a general recommendation by neurologists. Now, is there a test for primary progressive MS or MS that's coming down the road? And there is research on such things. There's research on blood tests to see if a person has very early MS that is not yet creating symptoms or seen on an MRI scan. But that's a different answer. That's an answer to the question is, are there tests that could show that a person has very early MS? Yes. The other question is, should we be doing it on all the family members? I think that needs to be, right now, that's not recommended to do MRIs, to do spinal fluid tests, because that's what we have right now. We have MRIs and spinal fluid tests to look if people are developing MS. Should they be done on asymptomatic family members? The general answer is no. Down the road, however, that may change when we start getting blood tests. And I'll tell you why. This is all research, all theoretical stuff. None of this is FDA approved. I'm just, letting you know. If the majority of patients or a significant fraction of our patients, the MS is triggered by the Epstein-Barr virus, wouldn't it be neat if you could vaccinate a young person like you give people measles, mumps, and rubella so that they don't get the Epstein-Barr virus infection? And there's research headed in that direction to develop those vaccines. But that research also includes is, if we do get those vaccines, is it safe to give those people these vaccines? Because mono has a habit of being actually nasty if you get it later in life as an adult. And let's say, you keep a teenager from getting mono, but suppose they get it when they're 30 years old because the vaccine effect wore off, and now all of a sudden they get terrible mono and a devastating other problems from that. So maybe testing people early might be useful if we then have something that we can do to those people to prevent them from getting MS. Again, this is all theory, but it's all hot topics. It's stuff that's being thought about. These are the hot topics right now at our MS meetings.
Thank you. Next one, going with age. Is it your opinion that patients should stop therapy at 69 if they've been stable for a long time?
Yes, some patients, now not everybody. Okay, this is another complicated answer for a very simple question. Should I stop my MS therapies? And I thought, man, did I accidentally skip that? Well, no, I did talk about it before. I'm just going to reiterate what I said and maybe other things I didn't say. There are studies right now to determine protocols for stopping MS therapies. Why would people stop MS therapies? Well, MS therapies expose people to adverse effects, such as skin cancer, such as urinary tract infections, respiratory infections. You don't want to be on them when you're getting older and nature's afflicting you with other things, right? You don't want to be on this stuff. Also, the economics of it. It gets more difficult to pay for these drugs. It's frustrating to take them, to keep taking a medication. MS goes through stages. In the later stages of the disease, the autoimmune or the immune component is not as prominent or prevalent. So you don't need to be on these drugs. Those are reasons to stop the medication. Now, when do you do it? And should you do it? Well, it's complicated. If a person's had very aggressive MS their whole life, early on, and their MRI looks terrible with lesions, but then they reach a period of stability. And now they're 65 and 60 years old and they've been stable. No new lesions, no new symptoms, stable exam for 5 years. Do I want to stop them? No, I'm not going to stop them. I don't want to stop them. I want to keep them on their med. If a person's been stable for many years, they've been on an MS drug, the MRI hasn't changed for a decade, they're a highly functional person, very little disability, and they're approaching, they're in their 60s, their 70s. Yes, it's reasonable to consider stopping the medication. Is there a probability of a relapse? Yes, I've seen it. I've stopped lots of people on their meds, either because the patient I decided to, or the patient had to. And when we did it in a controlled way, when we did it with logic or understanding, well, you've been stable, your MRI looks good, you've been on a mild MS therapy and you've had very mild MS disease, probability is you probably won't have a relapse. And a lot of them don't, but a few do. And that's the risk. It's interesting. I've seen patients that were in their 70s and they were stable for years. And you thought, their MRI is stable. They're doing great. They don't need to take this injectable anymore. And I'll be darned if in a couple years they had relapses. And one of my patients, they have relapses and they go back on their meds. But many more patients than that actually didn't have to go back on their meds.
Thank you.
Does that answer your question?
Doesn't answer mine, answers theirs.
What's yours?
No, I'm reading questions that people are writing in from online.
Oh, okay.
Okay, there you go. You don't want to see my questions.
Oh, okay.
Okay. All right. Next person says, my goodness, among the best presenters you've ever had. I was diagnosed at 47, but fit the description of the female diagnosed in her 20s when I look back. Regarding the prognosis that you spoke about, is it when you were diagnosed or is it when you look back and trace your disease symptoms?
You're talking about the untreated prognosis, I think, or untreated prognosis.
I don't know. She's listening. Maybe she'll get back to us and let us know.
Well, the papers that published those statistics, they were looking back at patients for years. Those are retrospective types of studies where they're looking at patients and how they did looking back in time, if I think that's what they're asking. But I think maybe I know what this person's asking is, can you see how a person is now, and can you predict how they're going to be in the future?
I don't think that's what she's asking. I think what she's saying is from the time of onset, if you look back regarding prognosis, is it when you were diagnosed with your symptoms?
I see.
So she just wrote, yes, untreated when I had my first symptom.
Yeah, it's I would not rely on the first attack, because you really need, and I've said this to people who are newly diagnosed who sort of just didn't want to be on meds, and they, what is this disease really going to do to me? And I tell them, I really don't know. There's some generalizations. You had a very mild attack. You had just sensory symptoms, and your MRI looks, just a few little spots. It's not that bad. Probability is you may do really well according to our statistics, but you really don't know until you follow a person for a couple years. So you got to be careful about making long-term generalizations and holding them like as this is the way it's going to be.
Okay, thank you. Next one. Would you recommend FES devices for MS patients with gait and foot drop?
Which type of devices?
FES.
Oh, functional stimulation? Oh, sure. Well, there are a lot of, so there are devices that, that use electrical stimulation to help with tighten the muscles in the lower extremities in particular. For example, in foot drop, to trigger the front muscles of the leg to actually lift the foot. So these are devices that surround the knee area. One's called the walk gait. And when it senses a person is a certain position in their gait, it triggers the nerve, it shocks the nerve, and it lifts up their foot. So those are devices to help improve gait. And some of them actually surround the entire limb and provide a coordinated stimulation of various musculature, like with the BioNest devices. I do recommend that physical therapists test those on patients who are having gait problems. There's other types of functional stimulation where muscles are actually stimulated and simply activated through electrical stimulation to sort of exercise them. And I think there's merit to that, and it does help.
Okay, thank you. What can you tell us about neurofilament light?
That's what I was referring to earlier, is that there's debris from neurons and that are being damaged in the nervous system. They release substances into the bloodstream, and these substances are an indicator of damage, and they can be used eventually when we have a good idea of how to use them properly. And that's the whole point with all the research being done and the studies being done on these neural filaments, these light filaments. And that is can we monitor these in the bloodstream to determine the efficacy of a person's MS drug? Can we look at these substances early on to see if a person is getting MS? And can we determine, is a person's MS quiet so they can stop their MS drugs? Or if they're not on MS drugs later in life because they stopped them for economic reasons, said, I stopped my MS drug, I can't pay for it. Well, we'll check their bloodstream and say, well, your MS is still active. It may not seem that way, but it's still gnawing away like termites. Maybe we better find a way for you to be back on a drug.
Thank you. So I don't know how many people have heard about the psionic neural sleeve.
Yes.
And would you like to talk to them about that, please?
Again, this is electrical stimulation of a limb based on transepidermal stimulation and activating the limb, like the lower extremity, for example, for the musculature to work to contract, for muscles to contract during certain actions to give strength to that limb. And these can come in for the leg, and they can also come in the arm. And the neural sleeve, again, this is functional stimulation, and I think these things are great. I think they should be tested on people, and I like to see their prices go down. I'm all for it.
It's not just the price go down, it's that they're not even covered by insurance.
That's the problem.
Right. Okay. So the neural sleeve that they're talking about is worn up to the top of the thigh, and it cannot be worn where you might get wet because you might get shocked.
Yeah, there are always there are some complications with things like this.
Okay, next question. Person asks, what are your thoughts regarding de-escalation therapy? Is there any other subgroup that would benefit from it?
De-escalation therapy. So that means going from a high efficacy medication like B-cell depleting drugs, and I'll name some of them. I'll use is it okay to use the company name because people hear them?
Just say the name of the medication. Say the name of the medication. I think they would know the name better than knowing the pharmaceutical name.
Okay. Medications like acrelizumab, ublituximab, ofatumumab.
Street language.
Oh, street language.
Yeah.
B-cell depleting drugs. Yeah. Kesimpta, those meds are really immunosuppressive. They're great drugs, okay? They're great drugs, but they're very immunosuppressive. Should they be used for a decade or 2 decades? Can the body tolerate all that immunosuppression? We're studying to determine whether or not that's the case. The case of should they be used for very long periods of time, or should we use them for briefer periods of time because they're immunosuppressing people too much, and then fall back on a lower efficacy medication or medication with a little less immunosuppression? that is one aspect of de-escalation. The other aspect of it is hit MS hard early on with our most potent drugs, which I think personally, is my opinion, I think is the way to go, and then back off on this later in life and use drugs that are a little safer. That's my opinion, but there are studies out there that are looking at this, and in the next couple of years, we're probably going to get some standard of care type of recommendations on these things. The other is escalation therapy. You start with low efficacy meds, and as the disease gets worse, then you escalate. And to me, that's never really made sense, because you want to hit the disease hard early on. But as one of my old mentors said, some people respond really, really well to some of our older, less efficacious medications that are gentler and have less potential devastating side effects or adverse effects. Let's give them a chance to see if they do well on those. Well, it may take a few years to figure that out. Meanwhile, the MS is hitting this person hard, and we don't want them to accumulate lesions. So my opinion is I like, high efficacy therapies earlier on, then de-escalating later on. If you agree, this gentleman, I haven't known him for very long, but I know he doesn't say anything that's not accurate or well thought out.
So I have a question and a half. It's about my previous question about the psychosis, and that
Yes.
so that's the half part. How common is the psychosis and hallucinations and all of that?
In my clinic, and this is no exaggeration, I know I have over 1,000 patients in all my clinics, more than that. And I have found that to be fairly low probability. Not the depression, but the psychosis. Psychosis is a whole different thing than depression. Psychosis is very abnormal behavior and hallucinations and things like that. Depression, however, unfortunately is very common in MS, but that's not a psychosis.
Yes, sorry, this is my actual question. Just want to follow up. So I've been hearing a lot of things other than the Epstein-Barr virus being like the
Yes.
cause of it. I just want to know your takes about the other things. Like the craziest one I've heard is aluminum. Like aluminum cans cause MS. So I don't know.
I don't know the answer to that.
Okay.
I honestly, I don't. And I can't say no and I can't say yes. I don't know. Just like does aluminum cause, Alzheimer's disease? I mean, there was years back, I think when I med school, there was a big thing about aluminum, I think. And does it cause autism? Who knows?
Probably the easy answer is when Charcot discovered MS, there was no aluminum.
But there are fewer cases. Yeah. Yeah. I think life was easier then.
Earlier, you
There was no
talked about,
internet.
you spoke earlier about nerves remyelinating. Are you talking about neuroplasticity or something different?
Well, plasticity and remyelination are probably two different things. Remyelination is a nerve, an axon. Probably I assume that everybody knows what I'm talking about when I say axon. I apologize for that because, we have so short a time. We skip details sometimes. The axon is the wire that comes out of your nerve cells, and it sends a message to the next neuron or to muscle. It's a tube. It's a simple tube, but that tube has electrical channels on it. They're like little doors, and when those doors open up, sodium and potassium crosses those channels, and it's that movement of those ions that creates an electric current. It's a current. And that current travels down the axon a little bit until it gets to the next place where you have those channels. And those channels sense that current, and then they open up. And then another current is generated, and you get what's called saltatory conduction, a jumping of the current, dun, 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 down the axon tube. And current, as you know, is electrical stuff, gets shorted out. The myelin surrounds that. Okay. Now, myelin, if it gets stripped from it, and it can in central nervous system diseases like MS, and it can in peripheral nervous system diseases like Guillain-Barré, as long as the axon is still there, as long as there's a scaffolding there, the cells will put it back. They'll put it back. That's called regeneration. That's a regeneration. Okay? If you cut the end of a sensory nerve, like, you with a piece of glass. Those nerve endings will regenerate and find their way back to where they would go, even if the nerve has been cut near a muscle. Now, if a nerve is cut close to the cell body, it'll die. Okay, so that's regeneration, remyelination. That's different than plasticity. Plasticity is a whole different thing. Plasticity is, for example, you have a stroke or you have a terrible MS attack and the cells are cleared out and destroyed. There's nothing there anymore. There are no more circuits that are regenerating. Instead, the mind or the body, if it has the potential to, it'll try to find other routes to get the message down to where it should be through physical therapy. And it's not easy in the central nervous system. That's why you got to protect it. We have to protect it. And that would be plasticity. And frankly, we don't have a lot of potential for plasticity. We have ways of relearning things that are higher level cognitive processes. If we lose some of this process, maybe we can relearn it somewhere else and find the connections to act on that process. For example, in children that have had a stroke, can do really well, even though they've lost a chunk of their brain. Another part of their brain has enough plasticity at that time to take over, to learn what it needs to learn, to find those routes, to then act on those thoughts. Does that make sense?
Thank you. We're going to call it a wrap, all right? We got more questions, but, it's getting late. I've got to get on a plane early in the morning, and we're going to say goodnight. So I want to thank you for what you were doing. Thank you very much.
Thank you for listening. And it was a pleasure being here. And I want you to know that I'm only a human being. If I said anything that does not jive with data or what you've been taught, I sincerely apologize.
Yeah, well,
I knew that cancer question was going to get me.
Thank you. I have one question for you all. Did you enjoy the presentation? Thank you.